Ladies and gentlemen, welcome to our, I think this is the third AFOMP school webinar. Actually, we have a monthly webinar and the school webinar. So this is a school webinar. It lasts about 3 hours. So we have 3 speakers today, and the moderator today is Professor Chai Hongyuan. I will give her a brief introduction. So Dr. Chai is a professor of medical physics at Taylor's University, Malaysia. She's the current president of the Southeast Asia Federation of Organization for Medical Physics. Also, she's the chair of Medical Physics World Board, International Organization for Medical Physics, and the vice president of the Malaysia Association of Medical Physics. She's one of the founders of the Asian College of Medical Physics. She's also an IAEA expert for multiple IAEA task groups and the regional activities. She was the recipient of International Union of Pure and Applied Physics Young Scientist Award 2021. And she's been the first Southeast Asia who received this prestigious global award. Her research areas focus on diagnostic nuclear medicine, interventional radiology, and the 3D printing in medicine. She currently owns 4 patents and has published more than 80 journal articles, 2 academic books, and 2 book chapters. She is the editor of the E-Medical Physics World Bulletin and the IOMP newsletter. She also served as review for several internationally renowned journals. So let's please welcome Professor Chai to moderate today's school webinar.
Thank you very much.
Thank you.
Thank you, Professor Jin, for the very nice introductions. Yeah, so I'm Chai, I'm from Malaysia. So welcome to this third AFOMP webinar for the 2023 series. So today we have very interesting topic. It's a MRI-Guided Radiotherapy. And we also have 3 very prominent speakers from Hong Kong. So they will share with us the experiences in using MR-Guided Radiotherapy. So the session will last for 3 hours. We will keep all the Q&A in the end of the sessions. And please type in your questions in the chat box whenever you have questions. And we will attend to your questions in the end. Right, so this is the schedule for today. So we're supposed to have a first speaker is Professor K.Y. Cheung. Professor K.Y. is not online yet. He's coming. He's here?
Yeah, he's online. Yeah.
All right. Okay, so Prof. K.Y. is here now. Right, so shall we follow back the schedule? Are you ready, Professor K.Y.?
Yeah, I think you can introduce.
Yeah. Yeah, he is sharing the screen now. Yes, I can see it.
Okay. Let me see my PowerPoint.
Yeah.
Can you see my PowerPoint?
Yes.
Okay, good.
Yes. Yeah, Professor K.Y., so we will start with your talk. So before we start, let me introduce.
Open up the, okay, please go ahead. Thank you.
Okay, so let me introduce Professor K.Y. So, sorry. Professor K.Y. is very famous in the AFOMP regions. He is the chairman of the Hong Kong Institution of Physicists in Medicine. He is the founding president of AFOMP actually, and he was our past president of IOMP and IUPASM. He's currently practicing as a senior medical physicist at the Medical Physics Department, Hong Kong Sanitarium and Hospital. He is also an adjunct professor at the School of Medicine and Health Sciences of Tung Wah College. He's also an adjunct associate professor at the Department of Clinical Oncology, Chinese University of Hong Kong. So without further ado, Professor K.Y., it's a great pleasure to have you here. You can start your presentation anytime.
Yeah, thank you, Dr. Yeong. For the kind introduction. And please excuse me for my voice and probably occasionally interruption. I just recovered from COVID-19 infection. So I might be a bit slow today. Okay, I'm going to talk on the principle and rationale of MR-guided radiotherapy. In that, I shall discuss the importance of imaging, particularly MRI, in high precision radiotherapy treatment planning, and then the challenges in delivering high precision radiotherapy treatment, and the importance of MR-guided treatment delivery, and the rationale for adaptive radiotherapy and MR-guided adaptive radiotherapy. Okay. Now, we turn off the, okay. Now, on the right is a plan showing the dose distribution of a very high precision treatment. We have this particularly in fluorescetic radiotherapy or fluorescetic body radiotherapy. In that, very small margins are used to achieve the clinical benefit in this kind of treatment. And the quality of the treatment and hence the clinical outcome of this treatment plan is strongly dependent on the uncertainties involved in the treatment and pre-treatment process. And that means we need to minimize the error involved in every step of the radiotherapy process. Okay. Okay, let me, okay. So now to achieve accuracy in radiation therapy, we need, as I mentioned, we need to minimize the uncertainty in every step in the process, and particularly in the delineation of the target volume and the OAR, the organ at risk, and also the treatment planning process and those calculations algorithm used in the planning. Patient immobilization, patient positioning, and target localization during treatment is also important. And most important is that whether you can deliver the dose according to the treatment plan. So in all these processes, good image guidance is crucial in each one of these processes. We have gone through tremendous improvement in treatment planning. Initially we started with 2D planning, and then the improvement made over the year. The breakthrough probably, the biggest breakthrough probably is the inverse planning and the implementation of IMRT. And now Monte Carlo dose calculation has been improving the accuracy of the dosimetry of the treatment plan, and hence we can produce extremely good quality treatment plan. We have been using different imaging modalities to help our treatment planning. For instance, we have the CT simulator, the MR simulator, and now recently the PET-CT simulator. And they are basically diagnostic, good quality diagnostic imaging machines. And the major differences is that they use flat tabletop, and also they have normally larger scan bore size to accommodate patients a simulation or scanning under radiotherapy treatment position, so that the image acquisition for treatment planning and treatment delivery are basically the same, so that the uncertainties involved during the image registration and contouring process will be minimized. The question is, why do we MRI is getting important. These two images shows probably explain the main reason why. On the left is the MRI image. You can see clear structure of the soft tissue in this of the body. On the right is the CT image. You can hardly see the structure very clearly. You need to use marker to identify the location of the target. But then you only you can locate accurately a point in the target, not the whole volume. And you also cannot delineate clearly the normal tissue. And so MRI do give you the quality we need for treatment for good target delineation and also OAR delineation. And MRI used to have geometrical distortion, and the current generation of MR have highly homogeneous magnetic field, and also they have low geometrical distortion scan sequences, which can achieve a distortion of less than 1 millimeter within a volume of 30 cm diameter square. So the issue of geometry seems to be basically resolved. We have also been using other imaging modalities such as PET CT image. In this case, on the left is the a CT image and also a PET image. And this PET image has the hypoxia tracer used, and which highlights the location of the hypoxia region, so that you can give those escalations to improve treatment outcome. So with multimodality images, we can generate pretty accurate and high quality treatment plans such as these. And with improving patient immobilization tools and also excellent planning optimization tools and accurate dose calculation algorithm, we can generate really high precision treatment plans. The remaining question is whether or not we can deliver such precision of the dose to the patient according to the treatment plan. And to do this, we have gone through tremendous improvement in treatment delivery over the years, from teletherapy to linear accelerator and to image-guided CT, combined CT-guided treatment delivery system, high accuracy, gamma knife, cyber knife, chemotherapy, and now particle therapy. And also, apart from good delivery system, we also need to have good image guidance system. And that has improved a lot over the years, from photo image to electronic photo imager to ultrasound, orthogonal X-ray, MVCT, KVCT, in-room CT, and now online KVCT. And this has improved a lot in localizing the treatment target for those delivery. And these are a few examples of we have experience on the top left. We have the photo imager, a linear with photo imager, and then we have the KV imager and KV coded CT. And now there are good quality ultrasound for treatment, for guiding the treatment of abdominal disease, and tomotherapy with KV CT built online. Orthogonal X-ray has also been used, for example, in the Novartis SRT system, and also CyberKnife using orthogonal X-ray. In-room KV-CT has been used also for conventional photon therapy as well as particle therapy. And mobile phone beam CT, in this case, for particle therapy. And also we have KV and MV phone beam CT with LINAC built in a ring type of treatment gantry. The problem with X-ray guided treatment, imaging guided treatment is that X-ray CT do suffer the poor contrast for soft tissue. For bone and high density structure, they are okay, but soft tissue is a problematic. So in these images, we can see that MR2 shows much better for imaging if we use for treatment guidance. And on the right also. What we really need is something better with better resolution, contrast resolution than CT. And MR seems to be the solution for doing that. Apart from localizing the treatment and deliver the dose to the right target, the existing practice also suffer from the possibility of organ changes or anatomical changes over the course of treatment. To address this problem, we can either use a sufficient large margin to cover the anatomical changes over the time, either during the course of treatment or during the treatment session when the organ do changes under certain situations. And using a larger treatment margin to defeat the purpose of high precision. And probably we need to do some adaptative kind of treatment. In that, we have to cater for anatomical changes by updating the treatment plan or by replanning. And for example, we do face a variation in anatomical geometry during the course of treatment. For example, the patient can, due to weight loss, can have body contour change, and human location, shape, and size can also change in response to treatment or non-response to treatment, deteriorating in size, for example, and also change in geometry of normal tissue, particularly in the pelvic and abdominal region. We also have, the patient can also have biological variation in their body. For example, the hypoxia issue and also tumor burden, in that the density of tumor cell or the activity of the tumor cells can change, can get worse or better. So we do get changes over the course of treatment and even during treatment. During treatment, for example, in the abdominal and thoracic region, organ do changes, do move. For example, due to breathing, biogas, heartbeat, and so on. And also patients also themselves move due to uncomfortable coughing, swallowing, and so on. So there is a need to correct for such anatomical change. The simplest way is to reposition the patient when we see a shift in target, for example, or we can use motion compensation when the target moves caused by breathing. And could there be significant changes in anatomy, we probably need to do some replanning. And so to address the issue of intra and intrafractional anatomical changes, one way to do it is we can use a larger margin to cover that. And again, this defeats the purpose of clinical objective of high precision RT. So replanning probably is a good way to do it. And this is what we call the adaptive radiation therapy. And the idea of adaptive radiation therapy was first reported by Kin-Yin in 1997, in that he indicated that ART is a radiation treatment process where treatment plan can be modified at every treatment fraction or every treatment session using a systematic feedback of measurement to match the geometrical, anatomical, biological, and physiological conditions of the treatment target and organs at risk. And that is the basic concept of adaptive radiation therapy. The objective, of course, is to improve the dose conformity under different various anatomical situations and to minimize treatment-related complications by using a tighter margin. And also by doing this, you can achieve to use dose escalation to give a higher dose to improve the cure rate. And also you can use less treatment fraction to because of less complications to facilitate what we call hypofractionation treatment scheme to improve the treatment outcome. Now, there are three modes of treatment in adaptation therapy: offline ART, online ART, and real-time ART. In fact, we have been doing offline ART for many years. What we do is we repeat volumetric imaging, CT, MR, and so on, for replanning at certain stage of the treatment course to correct for any anatomical or biological changes in patients to ensure that the adequate dose can be delivered to the target volume, at the same time better protect normal tissue. And this has been practiced for a long time. But this change in plan is not frequent. And also, even with the new plan, you don't immediately apply the treatment on the same day. It has to be on subsequent treatment. So there is we compromise the outcome of the we compromise the treatment by not making compensation in time to cater for anatomical changes. Online adaptation probably is the way to go, in that we do imaging on the same day of the patient treatment session when the patient is on board on the treatment table. So the treatment machine must be integrated with some imaging system, allow you to acquire diagnostic quality images for online planning. So you do replanning while the patient is on couch to correct for anatomical changes to improve the dose coverage to the target and reduce normal tissue irradiation. And then you do the dose calculation, and the plan is accepted by the oncologist, and then a QA has to be performed before treatment delivery. And during treatment delivery, because you have an online imaging system, you can monitor the patient anatomy while the beam is being delivered. In real-time ART, unfortunately, it cannot do real-time online replanning. What it can do is it can online compensate for geometrical adaptation. When the target is off position, then the system can automatically adjust the beam or adjust the patient to deliver the dose, exactly cover the target and minimize the dose to normal tissue. The accurate radiotherapy clear RT and the synchrony system are supposed to perform this function. The accurate CyberKnife can also deliver this online adaptation. The limitation of real-time ART, of course, it doesn't have online replanning, so it's purely geometrical correction. Now, online adaptation can do the replanning online. And currently, there are two main types of systems. One is the CT-guided adaptation system, the variant E4, and the other type is the MR-guided, is the electric system and also the wheel-ray system. As I mentioned earlier, CT-guided ART do have limitations in certain part of the body, particularly abdominal region. In this case, on the left is the MR images and also CT image. You can see, compare the difference. You can actually see the target and normal organ very clearly. For CT without marker, it's quite difficult to see. And also on the right also for liver. And MR-guided treatment system, you can have a clear diagnostic quality image with the MR images for you to delineate the target and OAR quite precisely. And there is no extra ionizing radiation. So there is, and my colleague, Dr. Kin-Yin, will talk about more detail about adaptation using MR-guided RT. So just a short summary. We have potential advantages of MR-guided adaptation therapy in that because the high quality MR images, we can accurately and precisely contour the target and OAR online while the patient is on treatment position. And we also can do replanning online. And also during treatment delivery, we can actually monitor the anatomy using online real-time imaging. And it is also possible to track the target. You can see the target motion clearly so that you can do tracking with MR-guided treatment system. In additional, MR system can also have functional imaging possibility. So it is possible that online response-based ART may be possible. And these are two examples. On the left is View-Ray MR ART system, and on the right is selector system. And just a short description, just a short summary, in that the workflow of ART. In this is an elector MR index. The patient is positioned, a 3D MR imaging can be acquired, which can be used for compare with the treatment plan, and also the simulation images. Could there be a significant anatomical changes? We can do online adaptation planning, and then those recalculations, and then quality control on treatment plan. And after the process, we can do a position verification again, and then when everything fine, we can deliver the treatment. And during the treatment, we can monitor the anatomy during being delivery. So that the workflow is quite simple, but the work involved is quite enormous. And to summary, on this talk, I just discussed that high precision radiotherapy may be realized in the clinic, provided you can actually see and localize the target and deliver the dose precisely. And multimodality imaging for treatment simulation and planning has improved the plan and precision and dosimetry enormously over the year. And MR-guided treatment delivery have improved the accuracy of the treatment delivery, and MR-guided adaptation therapy further improve the quality of treatment by online correction of anatomical changes while the patient is on treatment table. And with this slide, I thank you for your attention.
Thank you so much, Professor KY, for the very good introduction on MR-guided radiotherapy. Yeah, so for all the participants, if you have any questions, please type in the chat box and we'll attend to your questions in the end. So next, I would like to invite Dr. Kin-Yin to present his topic. Let me just pull out the slide. Let me introduce Professor Kin-Yin. So Dr. Yuan graduated as a from Electronic Engineering Department of Tsinghua University, China, and he obtained PhD from the Department of Electrical and Electronic Engineering, University of Hong Kong. He then worked as a postdoc fellow in Harvard Medical School. After postdoc training, he joined the Chinese University of Hong Kong as an assistant professor. From 2014, he joined Hong Kong Sanitarium and Hospital as a researcher to explore the pioneering research applications of radiotherapy. Dr. Yuan has intensive experience on MRI research for around 20 years. His current research interests include non-sequential and MR-guided radiotherapy. He has published more than 100 journal articles and more than 150 conference papers. He is the associate editor for several esteemed journals, such as Journal of Magnetic Resonance Imaging, JMRI, Medical Physics, and Quantitative Imaging in Medicine and Surgery. He's appointed as an honorary associate professor at the University of Hong Kong. He's also an active reviewer for many academic journals and top international conferences. So without further ado, may I invite Professor Kin-Yin to present his topic on MR. You can share your screen now, Dr. Kin-Yin.
Okay.
Yeah.
Okay, can you see the screen?
Yes, we can see your screen.
Okay. Can you hear me clearly?
Yes, very clear.
Okay. So thank you for the nice introduction. by Dr. Chai. So good afternoon, ladies and gentlemen. So it is my great pleasure and honor to be invited and have this opportunity to present the topic of MRI in radiotherapy, or MR in RT. So here is the outline of my presentation. First, we will introduce why we need to do MRI in RT. In this part, the clinical background of imaging in RT will be briefly reviewed. Then, the advantages of MRI over other imaging modalities for the current imaging-guided radiotherapy will be introduced. Next, we will present what to do and how to do with MRI in RT. The first one is the simulation scan and planning MRI, normally conducted on MR simulator. The second task is online MRI, which is conducted during the treatment session at each fraction, normally using an MR integrated linear accelerator or MR-Linac. For both planning and online MRI, in the current clinical practice, we heavily relied on the anatomical MRI, but in the future, the role of functional MRI may become more and more important. So after introducing the planning and online MRI, we will also briefly introduce some promising functional MRI techniques. In addition to the current MR in RT techniques, we will also discuss the future development of MR in RT. And finally, I will give some take-home messages to summarize and conclude this talk. And imaging is a cornerstone of radiotherapy in its history. The use of imaging is propagated into every workflow step of the clinical practice of RT, so including the simulation, treatment planning, positional replication, and to the treatment response evaluation. And ultimately, the RT outcome will are only as good as the imaging they are based on. So now we are in the era of image-guided radiotherapy. Many modern radiotherapy machines have been equipped with a variety of onboard imaging modalities, such as the combined CT or CT on rail, ultrasound or MVCT, and X-ray and optical imaging. Now the question comes, why do we still need the MRI in RT and MRI-guided radiotherapy? To answer this question, we need to take a look at the advantages MRI can offer over other existing imaging modalities. The current IGRT is normally associated with the inadequate soft tissue contrast, so that they heavily relied on the implanted fiducial markers. And the most current imaging modalities on the treatment machine also have the radiation dose so that they cannot be used too frequently or for a long time. Meanwhile, they often have limited functional imaging capability to reveal tissue properties other than anatomy. So in a sharp contrast, MRI offers superior soft tissue contrast. And it is the gold standard of soft tissue imaging in the clinical practice, particularly in the diagnosis. And furthermore, it has rich functional imaging capabilities like the DWI, DC, MRI, MR spectroscopy, and many other functional techniques. And they hold potentials in the treatment planning, guidance, adaptation, and response evaluation. Last but not least, a dynamic MRI during the dose delivery makes real-time gating and tracking technically feasible for better irradiation precision. Okay, the advantages of MRI can also be summarized to be 5 C's in layman's language. They are: see clearly on what you treat, by using the anatomical MRI. And second, see more on what you treat by using the functional MRI. And you can see earlier before you treat for prognosis and prediction. And you can see closely when you treat for motion monitoring, gating, and even tracking. And after treatment, you can see change and adapt, or during your treatment, you can adapt your treatment. And after introducing some backgrounds, now we will move to the simulation scan and planning MRI. So the planning MRI and simulation scan are usually conducted on MRI simulators. So MRI simulators, or called MRC, are usually modified for the normal MRI scanners to facilitate the RT applications. But it has some distinct features. First, it usually has a large bore size of 70 centimeter diameter to facilitate the use of some RT accessories. And second, an additional 3D laser is equipped with an MRC for patient positioning, so in line with the CT scene. Also aligned with the RT standards, an MRC uses a flat tabletop with RT index for simulation scan, instead of the curved patient table for the normal diagnostic MRI scan. And finally, a radiofrequency coil cannot be placed directly on the patient body because it deforms the anatomies. So instead, coil holders or bridges are used to scan the patient in the treatment position on an MRC. And to better illustrate the MRC and its distinctive coil setting for simulation scan, these slides show you the pictures of 3 MRCs of different vendors and their different coil settings for a typical head and neck simulation, compatible with the thermoplastic mask immobilization. So how to set up an MRI simulation scan on an MRC? Although such setup might be quite different for different scanned regions and on different vendor scanners, there are some general considerations. At the very beginning, we have to pay attention to the MRI safety issues. So this is similar to a normal diagnostic MRI scan. So always remember to wear the earplugs or headphones for the patients to protect the hearing, because most MRI scans are very noisy. So different from a diagnostic MRI, so patients need to be scanned in the treatment position. So it is easy to understand for the RT professionals. And regarding the coil choice and setting, so we have to choose a coil that its scan coverage is not too much or not too big or not too small. We also need to choose and place the coil to maximize the signal to noise ratio and minimize the scan time. We also need to consider about other factors such as image intensity, homogeneity, patient safety, and comfort, and setup easiness and efficiency. So I will explain these items in detail in the following slides. So in these slides, the 3 pictures show you some examples of patient positioning in coil setting for different scan regions on an Philips MRC. But what is invisible in these pictures is the use of the posterior coil. So this coil is positioned under the flat couch and usually used to cover the posterior anatomies. Okay, here below the tabletop, okay, is the posterior coil on the MRC. And besides patient setup, we also need to consider about MRI simulation scan protocols. In order to better know how to build an MRI simulation scan protocol, we need to first understand the different purposes of an MRI simulation scan for diagnostic MRI scan. Normally, diagnostic MRI scan is used for detection, characterization, and staging of the disease. But for a planning MRI, it is used to determine the true 3D disease extent and its relatively position to the adjacent organs at risks. After understanding this, let's look at some protocol setting considerations for an MR simulation scan. First, we want to obtain clinically useful image contrast for target and organ at risk delineation and easy to fuse to CT images. We also need to make a trade-off between the spatial resolution, scan time, coverage, and signal-to-noise ratio. Meanwhile, we would like to minimize the image artifact, for example, the motion artifact, susceptibility artifact, or distortion. Last but not least, we have to pay attention to the patient safety, just as we discussed before. Setting up the simulation scan protocol is most meant to choose and optimize the MRI pulse sequences. So we have to know what MRI pulse sequence is and understand how MRI pulse sequence works. So in addition, MRI pulse sequence is a computer program to initiate and control a series of events compromising the RF pulses, gradient waveforms, and data acquisition to manipulate the mechanization and to produce the desired MRI signal, and then acquire the signal. An MRI pulse sequence normally includes some components of RF pulse, the gradients, and the data acquisition. And its aim is to obtain the mechanization manipulation to generate the desired contrast and with the signal-to-noise ratio as high as possible and within a scan time as short as possible, while limiting the imaging artifacts. But note that the MRI pulse sequence is quite application dependent, so there is no single sequence perfect for all applications. Now let's look at how to choose the pulse sequence for RD simulation scan. There are mainly two types of MRI pulse sequence category. That is the spin echo sequences and the gradient echo sequences. They are both associated with many derivatives and have different vendor names. These two sequences have different characteristics, so are used for different scan tasks. For example, the spin echo pulse sequences have higher signal-to-noise ratio and less susceptible to B0 inhomogeneity, but usually have slow scan speed and specific absorption rates. They are excellent for high-quality anatomic imaging. So they are frequently used for the MR-guided radiotherapy. So on the other hand, gradient record echo sequences are fast, but more prone to the field inhomogeneity and have complicated signal characteristics. Some characteristics of GRE sequences and its comparison to spin echo are listed here. So due to the limit of time, we won't dig into the details of the different gradient echo sequence here. So here I like to mention that this sequence, the BSSFP sequence, it generates a T2 over T1 contrast. So it is useful for cardiac imaging in diagnostic MRI, but for MR-guided radiotherapy, it is the standards for the real-time motion monitoring on both MR-Linac machines, that is the View-Ray system and Electa's Unity system. Okay, the second question in pulse sequence selection is whether we should choose a 2D sequence or a 3D sequence for MRI simulation scan. So in this slide, some features of 2D sequence and 3D sequence are listed. We won't explain too much technical details. In general, for simulation scan, we prefer 3D over 2D sequences. And actually, 3D sequences are more frequently used in RT. After pulse sequence selection, we also need to set many other sequence parameters for better performance. For example, sometimes we need to suppress the bright phase signal in MR images. So we need to choose and optimize the phase suppression techniques. And similarly, FLAIR is often applied to suppress the CSF in brain MRI or spine MRI. In addition, we can also utilize different imaging acceleration techniques to shorten the scan time without much compromising the image quality. These acceleration techniques include, but are not limited to, parallel imaging and the partial Fourier, keynote view sharing, and the compressed sensing. For simulation scan, high geometric fidelity is crucial. So always enable the geometric distortion correction on your MRI console, either 2D or 3D for MRI simulation scan, to accommodate the MRCT registration, MR image intensity, non-uniformity in correction algorithms are also usually enabled for a simulation scan. So they have different solutions or different names on different vendors' MRI scanners. So here I'd like to show you some example images acquired in the MRI simulation scan in our hospital. So most of them are acquired with 3D sequences with the isotropic voxel size. Here are the head images, the T2 weighted image, and the post-contrast T1 weighted image. And here's the head and neck images. The prostate images is the T2 weighted anatomical image, and the post-contrast T1 weighted Dixon water-only image. And the abdominal images here. So here we use the high acceleration factor of 6 by using the compressed sense acceleration. Okay, this is the T-spine images, shows the T-spine bone metastasis. And after showing these clinical images, here I would like to also briefly talk about MRI-derived synthetic CT for the MR-only simulation. As we know, MR images cannot be used to calculate the dose due to the lack of electron density information. But techniques have been developed to generate the synthetic CT directly from the original MR images based on the different algorithms to facilitate MR-only simulation and treatment planning. A great advantage is that we can eliminate the planning CT, and we can also avoid the CT-MR correlation errors to improve the MR-GRT precision and simplify its workflow. So in recent years, commercial synthetic CT products have been released for different regions in the pelvis, brain, and head and neck. But it is also worth noting that current synthetic CT techniques also have limitations and are to be further improved. QA of MR-Sim is crucial to ensure high accuracy, integrity, and repeatability of MRI simulation exams. So QA is also important routine duty for medical physicists. Although MR-Sim QA has not been well standardized for different centers, there are still some general considerations. So AAPM Task Group 284 report is a very good reference document in this field and gives their recommendations on the QA test for MR scenes in the document. In the section 6, in this blue block. Okay, in our center, we designed and included the homemade cross-platform MRI QA test as a component of our daily QA protocols based on an ACR MRI large phantom. So this slide shows you some example images in this QA test and measurements based on these images, as well as our passing criteria. And geometric accuracy QA is also an essential part in MRI QA test. Some vendors also provide their QA solutions for the clinical users. In this slide, the images shows the geometric QA phantom and the analysis program provided by Philips on their MRCs. The automated procedure of this QA test, so including the phantom scan and the result analysis, also greatly eased the routine QA workflow. Okay, so after introducing MR simulation and planning MRI conducted on an MRC, now we will move to the next part of online MRI in MR-guided radiotherapy, usually conducted on an MR-Linac. So there are some commercial MR-Linac products in the market now. For example, view-raised MR-IBM system and Electa's Unity system, and some other MR-Linacs are still under development. Among these MR-Linacs, so Electa Unity is the only high-field 1.5 Tesla MRI integrated Linac in the market. So in addition to the routine anatomical imaging, so Unity also provides the diffusion-weighted imaging and the motion management solutions like the real-time gating. In this table, I compared differences between an MRC and an MR-Linac scanner. So some distinct features of the MR-Linacs are highlighted in the blue. For example, the gradient performance on an MR-Linac is compromised to trade for the better linearity, and the coil selection on an MR-Linac is quite limited. There are only 2 coils for selection, anterior and posterior coils. For the online workflow, the scan protocols are normally fixed, does not allow users to change these imaging parameters. So path sequences and the scan protocols are also different on the MRC and MR-Linac. They are listed in this table using the prostate MRI as an example. In MRGRT, the T2-weighted MRI is essential and the most important scan sequence. A 3D turbo spin echo sequence is a better choice than the 2D sequence for the better delineation of targets and organs at risk. And DWI also plays an important role in defining and delineating the dominant intraprostatic lesion. So it is recommended if DIL boosting is conducted, but currently on the Unity system, it is still a research sequence under development. And T1-weighted MRI, on the other hand, is an optional scan sequence because it has limited value in tissue delineation. In online MRI and the DC MRI is usually not allowed. And as I mentioned just then, the BSFP sequence, it is a gradient echo sequence. It is used for MRGRT for the real-time motion monitoring and imaging reference for the gating during the beam on time. And please note that the comparison in this table is only valid for prostate MRI, so it cannot be directly translated to other organs. As I mentioned, that the MRI sequence selection and optimization are much application dependent. The diagram in this slide demonstrate online treatment workflow on a 1.5 unity system. I won't spend much time on explaining the details of this procedure, since many contents are related to the adaptive MRI-guided radiotherapy. So I will leave this part to Dr. Kin-Yin, our next presenter. Here, you only need to pay attention to the several MRI scans involved in this online workflow indicated by the blue blocks. Okay, they are the daily MRI, verification MRI, and during the being-on time for motion monitoring or gating or tracking. So we call this the being-on MRI. And after those delivery, some post-being-on MRI can also be conducted. So as you can see from the last slide, the online workflow is quite complicated and involves efforts from different parties, like the oncologist, physicist, and RTTs. So in this slide, I just list the above mentioned different MRI sessions and their utilizations as a short summary. And in this slide, the T2 planning MRI acquired on MRCIN are compared to the daily MRI acquired on MR-Linac. As you can see, the planning MRI has a smaller voxel size. That is the isotropic 1 millimeter voxel size. And then the daily MRI acquired on MR-Linac and revealing more anatomical details, but it also associated with the longer scan time. So this slide demonstrates real-time motion monitoring of a healthy volunteer on the Unity by using the BSSFP sequence. Of course, it is being off. So the sequence here, we use the orthogonal linear acquisition with a frame rate of the 5 frames per second. Okay, after talking about much of the anatomical MRI for both planning MRI and online MRI, which forms the essential part and backbone of the current MRI in RT. Now we will briefly talk about the function MRI techniques. So there are many function techniques that have been developed and used to investigate different tissue properties. On the left side, I list some, but not all of these functional MRI techniques. For example, we have the diffusion MRI and the perfusion MRI and different sub-techniques in different categories, and the MR spectroscopy and the MRI relaxation time mapping, and both MRI, CEST MRI, MR thermometry, and even MR elastography. On the right figure, it illustrates how functional MRI can complement anatomical MRI in the case of a brain tumor. For example, in addition to the normal anatomical MRI of the post-contrast T1 weighted MRI, so DWI is acquired to indicate the cellularity of the tumor, and meanwhile, perfusion weighted imaging can be used to indicate vascularization of the tumor, and the Q-bolt imaging can be used to indicate hypoxia of the tumor. And due to the limit of time, we only introduced the diffusion weighted imaging in this talk because it is the only functional MRI method equipped with the current MR-Linac systems. So in physics, diffusion is a phenomenon to describe a thermal random walk of water in the biological tissues, also called Brownian movement. In the free water, the water diffusion is a constant at a certain temperature, but in vivo tissues, extracellular water diffusion is more restricted by the compact and dense tumor cells, which can be qualitatively characterized by DWI or quantitatively measured by the ADC apparent diffusion coefficients. In DWI, we acquired a diffusion-weighted MR image with a specifically designed diffusion-dependent gradient waveform, so which is characterized by the so-called B values here. Okay, the B value B. The tumor is normally shown as hyperintensity in a DWI image, in particular at high B value MR diffusion-weighted image due to the low diffusion restricted by the high cellularity of the tumor. But by acquiring a series of diffusion-weighted images with different B values and fitting this image intensity decay with B values to an exponential decay model, we can measure the ADC value for this tumor or other tissues. And by using the pixel by pixel mapping, so we can obtain the final ADC map of the image. So DWI is useful in the lesion detection, categorization, and delineation in diagnostic and planning MRI. In this case of the breast cancer MRI, the infiltrating ductal carcinoma, the IDC case, shows the hyperintensity of the tumor in the DWI image in the A, and the hyperintensity of this tumor in the ADC map indicated in the B. And this image, the three-color image, the blue, green, and red image, is coded based on a DCMR image. Okay, so we won't explain too much about this DCMRI here. And here, some DWI images acquired on an MRC and on an MR-Linac are shown. They can be potentially helpful for the dominant intraprostatic lesion identification for the dose boosting, as shown here by the yellow arrow. And DWI can also be used to evaluate treatment response of the radiation, of the radiotherapy. So before the treatment, the ADC histogram in the solid tumor is presented by a high, narrow peak concentrated within the low ADC area. And after the radiotherapy, due to the treatment-induced tumor death or cell death, the water is less restricted in its Brownian movement. Now the ADC histogram is presented by the low and wide distribution associated with the larger ADC values. So in the future, DWI may be also useful to be an imaging biomarker for the treatment plan adaptation. So although the current MR in RT has great advantages over other IGRT tools, there are still many technical and clinical limitations and challenges. Therefore, MR in RT techniques should be further developed and optimized to better fulfill its promise. So rigorous research and trials are also warranted to translate them into the clinical evidence and truly benefit patients. Some directions of the future development of MRI in RT techniques are listed here. So now it is a time to wrap up the talk. So in this talk, we mentioned that MRI is playing an increasingly important role in radiotherapy, and MR-guided radiotherapy offers some great advantages over the existing IGRT modalities and hold potentials to greatly improve the clinical outcomes in the future. In this talk, we also briefly introduced MRC and MR-Linac scanners, the patient preparation and setup for the MR simulation scan and online MRI, MRGRT, and the typical pulse sequences and scan protocols used in different scenarios. We also briefly introduced the DWI and its usefulness in RT applications. So despite great advantages of MR-GRT, we have to recognize that the current MRI techniques are not mature enough, still have limitations, so yet to be further developed for translating into the outcome improvements. Okay, finally, I would like to acknowledge our team members for their excellent jobs in the MRI in RT. So thank you so much for your participation and attention to this talk.
Thank you very much, Professor Kin-Yin. It's very, very informative talk. I'm sure the participants have a lot of questions, so we'll keep the questions in the end. Please type your questions in the chat box, right? So we will have more time for discussion after the last speaker. Right, so next we have Dr. Kimi to talk about MR-guided treatment planning in MR-guided radiotherapy. Let me introduce Dr. Kimi. Sorry, Dr. Kimi's name is Dr. Yeong. So Dr. Yeong obtained. Oh, thank you. Right, then let me share my screen. Okay. Do you see my screen? Right. So Dr. Yeong obtained his BSc with honor of excellent graduate from Nanjing University in 2007. In 2011, he graduated from the University of Hong Kong with a PhD. He was granted the professional qualification of certified medical physicist by Hong Kong Institution of Physics in Medicine with a demonstrated working experience and qualification in radiotherapy. He's currently working as an acting assistant senior medical physicist in Hong Kong Sanitarium Hospital. He has been serving as a counselor member of the HKIPM since 2019 and as an education and training committee member of AFOMP since 2018. His research interests are mainly in motion tracking techniques, MR-guided radiotherapy, and proton therapy. So without further ado, let me welcome Dr. Yeong.
Thank you, Professor Yeong, for the very nice introduction. So I just realized that today is a special day actually in China. So 20th May, actually the pronunciation of like the number 520 in Chinese just sound like I love you. So it's like a Chinese Valentine's Day. So I'm very happy that there are many audience today to join us. And I hope after this webinar, you could feel the love from all speakers and the AFOMP. So today, so this is the outline of my today's presentation. So in the introduction part, we will emphasize the importance of the precise tumor targeting in radiotherapy, and why adaptive radiotherapy is becoming more and more common in the modern RT. In the second part of the MRI-guided ART session, we mainly introduce the MRI-only offline and online strategies. So is MRI-guided ART perfect? Of course not. So we will tell some limitations of the MRI-guided ART, but more essential, the bright future of such a treatment technique by focusing on the functional imaging and the real-time adaptive methods. But finally comes the summary. So now, we all know that radiotherapy is one of the cancer treatments which utilize the beams of intense energy to kill the cancer cells. So radiotherapy could be performed using the X-rays, particles such as protons and even neutrons. So you may hear lots of the talk about the X-ray and the protons-based radiotherapy. But the boron neutron capture therapy like BNCT has some development and applications in recent years. So the most common types of the radiotherapy are external beam radiotherapy based on the conventional LINAC, MI-LINAC, 7 knife, gamma knife. And the second one is the brachytherapy, where the small pieces of radioactive metal are usually temporarily placed inside your body near the cancer, or permanently by some radioactive the implant seed. Third one could be the therapeutic nuclear medicine. So where you could swallow or by injection a radioactive liquid or capsule or by some drinks and into your blood to treat the cancers. So since radiotherapy uses high energy beams to kill the cancer cells, the tumor targeting should be as precise as possible. The effectiveness of the external radiation therapy could be attained if and only if that the target and organs and risk can be delineated correctly. Yeah, please be take it up into keeping in mind that the target delineation also has some uncertainties. And the second criteria should be that the patient is positioned accurately according to the treatment plan for the treatment delivery. So here I give some examples that, so the CTV is drawn by the oncologist, and the green dashed line indicates the PTV margin. So usually this is what we expect from the original plan. But what we may encounter in the actual treatment is like the below diagram, that the CTV may outside, sorry. I should give the pointer. Sorry, yeah, may outside the PTV margin. So how could we know that the CTV is outside the PTV margin? The answer is that imaging guidance. So the Harold Jones, who is a famous Canadian medical physicist, said, if you cannot see it, you cannot hit it. And if you cannot hit it, you cannot cure it, right? So the ITRT enables the visualization of tumors and nearby structures, allowing for more precise therapy for target volumes and organs. Through ITRT, we're able to reduce the severity and the risk of the therapy-induced complications of the AOAR and increase both quality and probabilities of success. And also with IGRT, we have some few further potentials in like broaden the application of proven therapeutics by monitoring the treatment response. And we could permit more therapies that are intolerant to geometrical imprecisions. And the common imaging technique used for RTRD could be the X-ray and MR, even PET, and ultrasound. So there have been a number of major advances in the precision of the treatment delivery over the years. So this diagram shows the evolution of the image guidance radiotherapy method in the upper blue one, and the corresponding imaging technique used for guidance. So the use of the 3D CT imaging led to the 3D conformal RT, and then the IMRT and the stereotactic body RT planning, which have dramatically improved the conformity of the dose distribution to the target. And also the installment of the imaging equipment, such as the orthogonal radiography, CT, or linear accelerator mounted cone beam CT equipment. So this allowed for frequent verification of the positions of the patient's positioning of the tumor relative to nearby critical normal tissues. And of course, we could use the on-site, I'll say the on-the-day imaging for the planned dose distribution verification. So the innovations in the imaging guidance have greatly contributed to these advantages, and the IGRT has increasingly become a standard of care for precise RT treatment. So although X-ray imaging is still very important for RGRT, so just as explained in previous two speakers, the X-ray-based imaging, of course, has many limitations. So the use of the CT or even X-ray images, even with the contrast agent, may not achieve the treatment goal because the target at some of the OER cannot be clearly identified in the X-ray-based imaging. Sometimes the imaging dose caused by the X-ray is also a concern. So, for example, if you use the real-time tracking based on the X-ray technique. However, the problem can be solved by using the MR because it is capable of visualizing the tumor and other organs without ionizing radiation. So here is one example of the cranial case showing the difference between the daily MR and the daily MVCT. So in the middle, you can see this is the treatment, this is the planning CT with the contrast. So oncologists contour the lesion here. And on the left one is the MVCT performed on the Radioset or the tomotherapy system. And on the right one is the daily MR images performed on a Siemens MR simulator. So the reason why we could have both MVCT and the daily MR is that in our center, we tried to, we have a clinical trial about the MRI-guided tomotherapy. So that's the reason why we could have both image modalities applied on one patient. So we can find that the MRI significantly improved the treatment verification accuracy. And with the MVCT only, it is very difficult to visualize the anatomical details inside the brain. You see, you can barely see nothing. And with MVCT, it is only possible to use to see the skull and bone and to use the skull bone as a surrogate for the registration. However, in the daily MRI images here, MRI images provided the necessary soft tissue details for precise tumor site matching. So this is another head and neck case demonstrating the monitoring of the treatment progress from the fraction 1 to the fraction 31. And for the upper one is from the MR simulator, and the low one is still the MVCT performed on the Radioset system. So with MVCT, you are able to show the patient or weight loss or the target shrinkage in a generic way. You can see the body contour dramatically changed after the whole treatment course. But it is difficult to quantify the exact physical response of the lesion. So is the tumor shrunk or is it totally resolved? So we cannot tell. So this is another brain case. With MRI, the tumor volume change could be clearly monitored. However, with the MVCT, you can see nothing. So if we are able to monitor the treatment progress and the response, so we may raise one question. When there are detectable anatomical changes in target or even OAR, shall we still treat the patient with the original plan? So what we expect from the original plan is like this. But however, during the daily treatment or after several daily treatments, what we encountered in actual treatments are like this one. The OAR shape changed. The tumor's volume shrink. Yeah, and both could happen, right? So how could we solve that problem? So Hall summarized the evolution of the radiation technologies in this review paper. And the treatment technique was developed to change from the 2D RT to the 3D conformal, and then IMRT VMAT, and with then it comes with the era of the RGRT, and then particle therapy. So the trend is to reduce the normal tissue dose. So we think the era of the adaptive radiation therapy has begun. So what is the adaptive radiotherapy? So ART enables the treatment to be changed or adapt to respond to a signal that additional information is known about the patient, or that the patient has changed from the original state at the time of planning. These words may be hard to digest, but here's an example. The changes in patient anatomy and all the deviations in the planned delivered dose due to the patient setup deviations or machine delivery deviations. And as a result, the implementation of adaptive radiotherapy is often being into the three major classes. The first one, offline, which means it happens between the treatment fractions. The second one is online. It means it immediately happened prior to a treatment fraction. And the third one, the real time doing a treatment fraction. So we give much more details about the offline ART. The offline ART is mostly used to address the systematic and progressive changes throughout the course of the treatment, such as what we mentioned before, the patient weight loss and changes in the tumor's morphology. So in offline ART, the adjustment to the patient, the treatment plan parameters, usually happens after the current treatment fractions. For example, when doing the daily imagings using like cone beam CT or MVCT, and you notice that the patient body shape get changed, patient got weight loss, but you still treat the patient with the original treatment plan for that specific fraction. But after that fraction, you may initiate the offline ART workflow. So the typical offline ART workflow usually follow the same clinical workflow as initial treatment planning, starting from the simulation and then the contouring and then the thorough planning and the physician approval and then the patient-specific QA, and the new plan will be implemented in the subsequent delivery stations. You can see actually the offline ART will involve lots of the resources and labor intensive. So I think that's why I think the concept of the ART has been raised like for decades, but it did not become popular like 20 years or 10 years ago. The reason is still that it is labor intensive and it needs a lot of resources. But now with development of the new technologies, we have more options and more useful tools for assist or to speed up the offline ART. For example, here I give the accurate, precise ART system. So actually, I have to say that commercial products related to the offline ART at the current stage is still more focused on the treatment dose monitoring. What does that mean? For example, in the accurate, precise ART here, actually it is a software tool fully integrated the daily MVCT or KVCT imaging for the fractional dose accumulation and patient data analysis and automated reporting system. You can see how here, the system will stitch the daily MVCT or KVCT images with the reference CT and then perform a new dose calculation on the daily imaging. And then the system will give you a report just like this, tell you whether some dose matrix is out of the oncologist's prescription, and you can make some decision to continue the treatment using the original plan, or you may need to initiate the offline ART workflow by replanning. And the second solution is like the CT on Wheel system. This part may save you some time on the simulation, because when patient on the treatment couch, and you use the CT on Wheel system to perform patient on the day imaging. And usually the CT on Wheel system has a diagnostic level CT image quality. So the daily CT images could be directly used for the replanning purpose. So the next one is the online ART. So we know that the offline ART cannot adequately account for the treatment variations that occur during a short time scales. So online ART involves the adjustment of the patient's treatment plan before the delivery of the treatment in order to reflect the temporal and the stochastic changes detected while the patient remains in the treatment position. That's a really amazing solution. So for the online ART, it requires, of course, need imaging and recontouring and rapid replanning. And plan review, approval, and online patient-specific QA. The speed is crucial for the online ART. And online ART aims to achieve a better OAR sparing and improve the target coverage and the target dose escalation, if possible, while maintaining the PTV, like the small PTV margin. So in online ART, there are some commercial system has been realized, like a CT and AFOMP CT guided ART system. The first example is that Varian itself AFOMP CTs based on the ART solution. The Varian itself system is a CT based system. It will deform the planning CT based on the daily AFOMP CT and get a very high quality CT images for the daily dose calculation. And it also use some AI algorithm to speed up the replanning purpose. And the second one could be the Accurate plus the research solution. So this one is not commercialized yet. And for some audience may just know that Accurate use the MVCT for the image registration, but I think two years ago, Accurate has used the KVCT solution now. So KVCT solution named Clear RT system. It can also be installed in the RadioDeck system. Which such KVCT system has very high image quality. And Accurate plus the research TPS, they could provide also a similar workflow just as the Varian system. And the third one could be the CT guided system by the United Imaging, the UCT ART solution. Yeah, as you may know that the United Imaging has a so-called CT guided LINAC, which integrates the diagnostic level CT scanners and LINAC. And then is the MR-guided ART, of course. Most MR-guided ART are based on the MR LINAC. So there are currently 5 different companies or institutions developed different MR LINAC systems, and 3 are commercialized systems. The first one is the ViewRe MRDN system, which has a 0.35, a low field magnetic field. And the second one, and which is the Electra Unity system, and installed in our system, in our center. So today's presentation will focus more on this high field MR linear system. The third one is the Aura system with the 0.5T Tesla and the 6 MV. This has got the FDA 510K clearance last year. And there are also two non-clinical systems by the Australian group and the prototype by a Canada group. So now the third category is the real-time ART. So what does it mean? The real-time ART has been introduced to account for the variations within a treatment fraction, including the respiration and the internal status changes. And the treatment plan is automatically adapted during the treatment delivery without the operator intervention. And the real-time ART could be realized through different approaches. The first one, for example, the treatment gating and dynamic tracking. And the second one is the intrafractional replanning by a continuous imaging with the constant replanning and the rapid dose calculations. You may notice that actually I divided the two different approaches here. The first approach, the treatment gating and the dynamic tracking, is more like the motion management solution. Yeah. And the second one, the intrafractional replanning, is like more related to the planning part. So let's talk about the MRI-guided ART. So here, example about the difference between the 2D simulations and the CT simulations and the MR simulations. Now we can clearly see the advantages of the MR simulation in the soft tissue delineation and OAR delineation. But of course, in current RT, the CT simulation is still the basis for the planning. So somebody has proposed an MR-only ART. So how could MR-only workflow be realized? So an important development for the offline MRI, the offline here I would like to emphasize is that means it outside the treatment session. So offline MRI implementation in RT has been the application of the pseudo-CT density data or the synthetic CT, so which allows for the MRI-only treatment planning by using the Huntsville unit pre-assigned to each voxel. So what is the synthetic CT or say the pseudo-CT? So for synthetic CT, here I give an example called the MR-CAT, which stands for the MR for calculating attenuation, developed by the Philips. This MR-CAT prostate package for generating the synthetic CT use a single Dixon MR sequence and a proprietary algorithm to generate the electron density informations. So from this white paper, you can see the M Dixon sequence gave the water images and the in-phase images. And these two set images will be used to calculate the body mass and then classify the soft tissue. And then the system will perform a segmentation of the bone mass and classify the compact and the spongy bone. And then based on the different structures, it will assign the Huntsville unit values. So this is I call it the generation one. So in the generation one, the MR-CAT algorithms, the Philips system used the bulk Huntsville unit assignment. So the Tangi performed the dosimetric and workflow evaluation of the MR-CAT for the clinical use in pelvis. They conclude that the dosimetric comparison between the original CT and the synthetic CT plans was within the 0.5% on average for all the structures. And the patient-induced susceptibility distortion based on the B0 maps was within 1 millimeter and 0.5 millimeter in the body and the prostate, respectively. And the DRR generated from the synthetic CT and the cone beam CT localization based on the MR localized fiducials show a standard deviation of less than 1 millimeter. They give a very promising result to suggest the robustness and the usability of the MRI-CAT images for the RT use. So, and then after several years, Philips gave a generation 2 algorithm of the MRI-CAT prostate package. In this generation 2 algorithms, it has been modified using a 2-stack Dixon sequences and developed to generate synthetic CTs using the continuous transfer unit generation, as well as for the general pelvis anatomy. So in the first generation, it can only be used for a male with a prostate, but now in the generation 2, it could be used on the male prostate, even rectum, and a female pelvis. And now, especially the transfer unit, the HU values are continuous. Here's an example of a male patient with a prostate cancer treated with our MR-Linac. It's more like a real CT. So another solution for the synthetic CT, recently there's a popular topics all use the AI solution or the deep learning solution. So we also have our own research teams using the AI algorithm, deep learning, to develop a synthetic CT. So we use a Bayesian deep network for generating synthetic CT. And especially, we are able to generate a so-called uncertainty map together with the generated synthetic CT. With that uncertainty map, we are able to predict the regional CT number error without referring to the original CT. And we could evaluate the quality of the synthetic CT without the original CT. And we could highlight and detect and even identify the imaging artifacts or the abnormal structures. So our work has been accepted in medical physics and should be online soon. So to mitigate the time-consuming and the labor-intensive aspects of manual contouring delineation of the target and OARs, so at the same time, to reduce the inter and intra-observer variability in contour delineation. So there are recent developments in offline ART. The first one could be the AI-based automatic structure identification or the segmentation in the treatment planning. And second one is the auto planning. So all AI tools are used to speed up the planning process to reduce the timing between the decision making and the implementation of the ART. So here I want to explain more about why the MI-only online ART is that important. So as I mentioned, in our center, we have treated like more than 400 patients in the MI-Linac system. And in our hospital, more than 75% of the cases treated in MI-Linac are SBRT. So every fraction matters for us. And from our statistics, 16% of the cases need online adaptation. And in our analysis regarding the decision of the so-called ATS means adaptive shape, this is a very special workflow named in Unity. I will explain this workflow in details later. So you just consider as the online ART. So the ATS implementation, so in the criteria, we decided to implement the ATS mainly, and we find that the reasons, most of the reasons are the anatomical changes. And also, the ATS decision was made most frequently in the fraction 1. And this is the paper we published actually last year. And in this paper, we give the statistics of our ATS decision making. And here I give some examples for the anatomical changes of the target or the OAR system. So why am I only online ART important? So I could give some more examples on that. In the first line, you can see this is the CT reference plan contour here. The second one is the daily MRI images. And the third one, if it is the adapted or the deformed contours based on the daily MRI images. So if we don't change anything, we treat it the original plan on the daily image, what will happen? You can see the rectum here will get very high dose. So if we choose the online ART workflow and use MR-Linac to adapt the plan, so we will get much reduced rectum dose here to reduce the toxicity of the rectum to improve the treatment outcome. So in the MR-Linac that combines the MR system with the Linac accelerator has been unveiled globally with the promise of overcoming the main limitations of the cone beam CT, and with respect to the anatomical change imaging and adding the potential of the physiological images. So with MR-Linac, the improved soft tissue contrast of the MRI allows for the better lesion delineation. And also, it is able to adapt the treatment to the exact location and size of the tumor, improved outcomes. So, and also, MR-Linac is able to offer the advantage of the improved visualization of the OAR. So this is the clinical workflow for our the Unity system. So as Europe, as in the RT treatment planning, the patient need to undergo a CT simulation and MR simulation. And oncologists will draw the contours in the OAR on the MR images, and then the contours will be transferred to the CT images. And based on the CT images, those matrices will create a reference plan. And once the plan is approved and the patient start the treatment, so on the treatment day, the patient will get the online daily MR first. And if once we find that the target or the OAR volume changes, and we decide to perform online ART, we will use the deformable registration to deform the contours. And you may notice that how could we solve the electron density or the mass density problem? Because what we have on the daily is just the daily MR system. Yes. So in the online ART system, we will use the bulk electron density override. The bulk density override on the daily MR images to initiate the dose calculation. And then with the electron density override, the MR images and the deformed contours will be able to create a new plan based on the daily images. And after the online replanning, we will perform an online physics QA and to make sure that the online plan is is okay for treatment. And before the final treatment, we also will perform a position verification of MR image to make sure during the whole progress of the online planning, the patient anatomy or the patient position doesn't change just before the BMR. If the patient that doesn't move or anatomy change, we will initiate another round of the replanning progress. And during the treatment delivery, usually we will use the intrafractional thinning MR images to observe if the target is moved outside the PTV margin. And here is an example to show how we perform the bulk density assignment. So the bulk density of the different structures are determined by the reference CT. So here, this tab is called the ADEPT setup in Monaco. And if you notice that there's a mean electron density here, these values are read from the reference CT. And during the planning, you need to confirm if the read values here will be transferred and will be used in the online ART. If yes, you will click this arrow here to transfer the mean electron density read from the CT to the future daily MR images. And this part is mandatory. And before you approve the plan, you have to review the electron density values. So let's talk about the challenges and opportunities of the MR-guided ART. So because in our system, we are using the 1.5T unity system. So there is indeed impact of the high field magnetic field to those calculation. The first impact is the shifted PDDs and the beam profiles. As you can see here, the red curve indicates the PDDs or the beam profiles measured with the magnetic field. And the black one is the without magnetic field. For the PDD, it will be shifted towards the surface. And for the profiles, it will be shifted to plus X direction. Of course, it depends on the direction of the magnetic field. So it is for the profile, it will no more be centered compared to the conventional linear. And the second one is the electron return effect. So what's the electron return effect? So when electrons moves from one medium to the another one of the lower density, as you can see here, here is the solid water phantom, and this one is the lung slab phantom. When the electron moves from the high dense material to a low density material here, there's an increase in the numbers of electrons looping back and deposit the energy on the interface here. There's a dose increase here. The electron return effect has a significant effect on the dose distribution near the heterogeneity and on the exit dose, according to some studies. But fortunately, this electron return effect can be well simulated and accounted for in the treatment planning system. So actually in most actual clinical cases, we didn't find the electron return effect will cause like significant problem to the plan quality. The third one could be the electron streaming effect. So if some audience listen to my talk last year, so I explained these three effects in details. And what is the electron streaming effect? As I show here, the beam coming from the anterior direction, and there may be backscattered electrons generated from this protruding surface, second electron here, and then because of the magnetic field, it will be streamed to the chain of the patient, causing some high doses here. And fortunately, this effect could also be well simulated by the molecular system. So you just need to pay attention to the existence of the problem and remember to check for some special cases if electron streaming effect will cause additional high dose in some protruding surface, like Cheung region when treating like Sorex cases. There's also some other limitations of the MR-guided ART system. It requires an extensive and considerable infrastructure and expertise, and most of all, a substantial time commitment over the traditional RT. And this task requires the attention of the radiation therapist and radiation oncologists and the physicists. And here the example showed our workflow. And each party has their own role doing the MR-guided treatment. And now, actually, our oncologists will could remote check the plan quality and the all the image registration. So oncologists could don't need to be on site. And you may find that the ATS or the online workflow will take like 78 minutes. It's very long, so it's very labor intensive. And also, the MR-guided ART has some MR safety issues. You have to deal with. You have to have some guidelines to deal with the metal implants and even electronic devices. For example, the pacemaker in the patient. So here I give example. This is called the MAC resources. It's a web-based searchable online database of the printable MR safety informations for the medical implants. So when the patient with the medical implants come and if patient give you the model number of the implanted of the implants, you may able to get the MR safety information of that implants on this website. And of course, you need extra training and expertise in the MR images, because sometimes you need to have some knowledge in optimizing the MR sequence to improve the image quality, and even for the functional imaging. So as mentioned by Dr. Yeong, the functional imaging is also getting more and more applications in radiotherapy. The current focus of the online MR-guided radiotherapy is adaptation to anatomical changes. But in the long term, we think that the biomarkers derived from the quantitative MR techniques are expected to enable adaptation to physiological structures and the treatment response. And here's some examples of applications of promising MR-derived biomarkers. The first is the dynamic contrast enhancing MRI. So it's able to characterize the tumor microvasculature. And the second one is the DWI images, and it will be able to image the random ground motion of the water molecules. And the third one is the CEST MRI. So I will not introduce into details about these techniques, but what we're going to know is that functional images will play an important role in the future RT, especially in the online ART. So now there's a new concept raised called and named the biological guided ART. You may heard of the a system named the reflection, which is the PET guided linear actually. So the vendor also called it biological guided ART. So biologically guided ART holds great promise because the changes at the physiological and molecular levels usually occur prior to the anatomical change, leading to the early treatment adaptation. And the patient-specific biological changes during the treatment have been shown to correlate with clinical outcomes and toxicity profiles. So however, the biological guided ART still remains limited in clinical practice. And the majority of the current studies focus on the adjustment of the target volumes based on the functional imaging. For example, the DWI images are obtained during the treatment course. So I would also talk more details about the real-time MR-guided ART. So the current mainstream solution, like for real-time MR-guided ART, is like the gating solution. So in gating, the motion is continuously imaged at high temporal resolution, and the radiation is only delivered when the tumor is at the specific location. Here's an example shown by the UMC U-Trend team. As you may know, for View system, the gating function has been realized on View system for many years, but now, I think Elekta announced their own motion management solution for Unity last year. And with that, the so-called comprehensive motion management solution, and now Unity will be able to realize the gating in such system. As shown in the sample, this magenta structure indicates the GTV or CTV, and the green structure indicates the tracking volume. So once the CTV or CTV is within the tracking volume, the beam will be irradiated. Once it's outside the tracking volume, the beam will stop. And the concept is very simple, just similar to the conventional RT solution, the gating concept. And the second one is MLC tracking. Of course, MLC tracking is not new for conventional RT. It has been realized in some conventional linear system, and also for the very famous product, the Cyberknife. Cyberknife has a synchronous system. It has a movable robot to track the volume. But on MR-Linac, it's kind of new. This movie shows a patient with a lung tumor, and during the treatment, if MR tracking is realized, so the MLC will track this the motion of the lung lesions without the interruption of the beam. So now, there's also there are also the limitations or the challenges for the real-time MR guided system. And we found that the methodology of the real-time dose calculation and risk construction is kind of a challenge or the limitation. One group proposed a tool for online dose reconstruction, which determined the delivered dose based on the pre-calculated dose inferences data in less than 10 milliseconds. It's very fast dose calculation. So this group used the deep learning strategies to empower the real-time dose calculation. And also, it is very important to speed up the deformable dose accumulation for the targets and OARs. And actually, the accurate dose assessment of the fraction intonated RT requires the deformable dose accumulation. And currently, no clinical usable solution has been proposed for this problem. So here comes a summary. So we know that the RT is essential for modern precise RT, and adaptive therapy is the trend. And it's, in my mind, is the trend of the personalized RT. In the offline ART, it will adjust the treatment plan after the current fraction. For online adaptive radiotherapy, it will adjust the treatment plan immediately prior to a fraction while the patient is still on couch. For the real-time ART, it will account for the variations within the treatment fraction. So MR-guided adaptive therapy. So we all know that the MR advantages over the X-ray images, and also this development in the synthesis CT, including the MRI-CAD or deep learning or AI algorithm to improve the solution of the synthesis CT. So we also introduce a workflow of the online ART. And then we show some limitations of the MR-guided ART, including the dosimetry effect caused by the magnetic field, and also some challenges, and of course, opportunities by utilizing the functional imaging and the real-time of the AI algorithm power. And I would like to take the chance to thank my teams, and thank you. And we would like to take any questions.
Thank you very much, Dr. Kimi. Yeah, thank you for the very informative presentations. I think their question already answered, so that's very nice. Okay, now the floor open for Q&A. We have received some questions from the participants. Let me just project it here. Okay, I hope you can see my slide.
Yes.
Right, yeah. Okay. So we have a number of questions. So question number 1 for Mukesh Meshran. I think this is to Professor KY. How much time needed for normal MRI-guided adaptive workflow? Or any one of you can help to answer.
Yes, I think in my slide, I have shown that our online ATS will take average time of 78 minutes. And this is for the SBRT.
Is it 70 minutes, Kimi?
Yes, more than 1 hour.
More than an hour. All right, okay, thank you. Second question, I think this is my former student. Thank you for the informative talk. May I know how was the QA plan done during?
Okay, I think I can answer this question. Currently, we use a software named RedCal. RedCal uses a modified Clarkson algorithm. So it's actually a point dose calculation. And we fit in the software with the PDD and the beam profiles. And actually, such algorithm cannot take the magnetic field into account. So it's we have to admit that it is not ideal to use the point dose calculation solution to use it as the online QA system. So more ideally, and also I think in the future, we will develop a 3D dose calculation for the online QA. And also we wish this 3D dose calculation will take the magnetic field into account. Yes.
Yeah, that's very nice. Thank you. The other question from Professor Fukuda. Thank you for nice presentation. I'm interested in the QA before delivery at the online MRI-guided adaptive radiotherapy. Could you explain how to perform QA before delivery?
Yes, actually the QA process is quite streamlined. Once when the online plan is done, so the dosimetrist or the radiotherapist will export the plan diagram to a location, and then we will fetch that data and into our own QA computer, and it's all networked. So we don't need to use USB or something. It's very fast, and we open the and we import that QA the diagram file into the RedCal software and just click calculate, and then we get the result. Yes.
Yeah, thank you. So, Kimi, how many QA tests that you need to do before delivery?
Before the delivery, yes. We if the reference plan based on the reference CT was approved, we will do a pre-treatment patient-specific QA. Yeah, by delivery, we will measure the point dose and using the arc check to measure the dose distribution and to make sure that the point dose is within 5% deviations. And we will able to achieve like more than 95% gamma passing rate with the 3% 3 millimeter criteria. And this is pre-treatment QA. And for online QA, yeah, as I mentioned, we use the red cal. And I can give more comments on the online QA. Yes, I just forgot to mention that. I think some group raised a very good point that if we need to perform extra QA on the electron density override, as I mentioned in my presentation, that I think most of the audience should understand that the daily ART workflow will use the electron density value transferred from the reference CT, right? For each structure, there will be a specific value of the electron density override. So some groups think we also need to do some QA for verifying if such the values are accurate. Well, that's a very good point, actually. So regarding this issue, some specific solution for that. For example, after the original CT-based plan is approved, you could save this plan as a new plan, and then on the reference CT plan, you don't use the CT table. Alternatively, you just manually override that each structure according to the electron density value you reviewed and approved, and then redo the calculation. You get my understand? So theoretically, if the density override value is accurate or there's no problem, you should be able to get a very similar dose calculation between the original plan and the manually override plan. Right, so this is one kind of method for like QA the electron density values. So, yeah.
Yeah, that's very clear. Thank you very much. So, Kimi, you do the QA for every patient?
Yes.
Wow.
This is the policy of our hospital. Actually, for the first in the first year, we performed the delivery QA for each treatment fraction. Yeah, for all the fraction. So we have accumulated lots of the data, QA data, and we have a publication to summarize all the QA results.
I see. What about now? Do you still doing it for every fraction? Are you still doing it?
No. Okay. I think we have accumulated enough good data, and we are confident about the system now.
I see. Okay, thank you very much. Right. So other questions from Dr. MD Anwaru. All the planning algorithms are delivered based on electron density, based as we are throwing X-ray to the target. What about the planning algorithm of MRI-based image? Is it the conversion of electron density to magnetic field, or itself different magnetic field-based algorithm?
Yes, actually, I think in my online adaptive ART workflow, so daily MR images will use the bulk density override. Yeah.
Thank you. And another question from Adiwasono. Agree to Mr. Anwaru, how MR images used to simulate dose distribution in treatment planning? How the MR images are used to simulate dose distribution?
I think it's a similar question about the electron density, right? So yeah, just in the daily in the online ART workflow, we define the structures and assign the electron density for each structures, and then make those calculations possible on the daily MR images.
Okay. So does that answer your question, Adiba Sono? If you are still here, you can type your comments. Right. So let's move on to the next question. Anissa saying, nice presentation. I have some question about MR-Linac. First, how we get the electrodensity information from MR image to do the calculation? Second, is it safe to use MR-Linac for patient who has metal implant?
That's very, I think I have answered the first question, right? The bulk density override. So the second question is is excellent question. Yeah, actually we do have a specific, also the guidelines for handling the patient with like pacemaker in the metal implant treated in the Unity. Maybe I can share screen to show. Oh, no. Wait, because I have, I had a presentation like last year in the Malaysia Consortium to talking about our experience about treating the patient with pacemaker. So basically when the patient with like pacemaker or metal implants come for our Unity treatment or MR simulation, we need to know the exact or the accurate information of that specific implant, the modeling, the model, the serial number or something. Yeah, and then as is indicated in my presentation, we do have online database, the MAC source, yes. And with the model and the brand, we will type in the information, and then we will be able to get the MI safety information regarding the specific the implant. And then actually the information provided on the website, we also give like the maximum SAR value and some recommendation or the limitation for the sequence which could be applied on this implant. So doing the MR simulation or the Unity treatment, we just need to make sure that the sequence fulfill the requirement by the vendor. So to guarantee to make sure the MR safety of the patient.
Yeah, thank you. I think that's very important. Okay, next question, Ramon Han. How far MRI? I need to mute the participants. Okay. How far MRI imaging is efficient in case of lung tumors as they have a less proton density compared to other tissues?
Okay, maybe I can say some words on this question. So let me try.
Yes, Dr.
Okay.
Kin-Yin. Yes.
Okay, so actually, to be honest, for lung imaging, so MRI is not a good choice for the anatomical image. Okay, so CT performs much better than MRI to get the lung anatomies, because MRI is slow and it is very subject to the respiration motion. So you will see a lot of the motion artifact on the MRI images. But for diagnostic MRI, we have some techniques to compensate this, to reduce and compensate this motion artifact. But for the MR-guided radiotherapy, the use of MR image is quite different for the diagnostic MRI. So actually in our center, we have treated very few lung cancer patients by using the Unity system on our MR-Linac. Okay, because many oncologists are not so confident that they can use this machine very well, so they did not refer to many patients for this machine. Okay, and as I mentioned, that at that time, our Unity system still did not have the gating function. Okay, so without gating, we cannot real time treat the motion during its cannot treat the tumor during its respiration motion. But after our update of the Unity system with the gating function, I think in the future, so we can try more treatments for the lung cancer patients. I think for the major advantages of MR-Linac to treat the lung tumors is its real-time motion monitoring and if with gating. So I think we will be much more confident to treat them.
Yeah, thank you very much, Dr. Kin-Yin. Okay, this one from Ramiro. Evidence presentation and no PTV margin for MR radiotherapy in your center. Second question, does PTV margin vary for different type of MRI scanning?
Okay.
Let
me try to answer this question. Okay, I will answer this question. So in our center, we treat mostly our case focus on the prostate cancer. So for the prostate cancer, our PTV margin is traditionally set as the isotropic 5 mm, except for the posterior direction, it is 3 mm for the rectum sparing. Okay, but actually in the future, I think the PTV, the traditional PTV concepts for the MR-guided radiotherapy should be greatly modified because we have the online adaptive capability to do that. So if we are confident about our online adaptation, and we also have the real-time motion monitoring and gating and even tracking. If we have all these capabilities, I think the PTV can be much reduced, or we can use some like the pseudo zero PTV concept. But I just want to express that the traditional PTV is not so is no longer necessary for in the area of the MR-guided radiotherapy. Okay, so at least for the time being, at current, we can reduce the PTV much by using its daily MRI image, because we can see the anatomical change with the treatment. So I think in the literature, so recently the UCLA UCLA group published a paper of their trial 3, their clinical trial of the compare the acute toxicity of prostate cancer outcome by using the MR-Linac and CT-guided radiotherapy, and they reduced the PTV from the 4 mm to 2 mm, okay, for the CT-guided radiotherapy. Okay, so that means that the PTV for the MR-guided radiotherapy is just half of the CT-guided radiotherapy, and the acute toxicity, GI and GU toxicity, are much significantly lower than the CT-guided radiotherapy. Okay, so if you have interest, so you can find this paper. So it is published on the Lancet Oncology, I think, if I'm right, or JAMA Oncology, or lung cancer oncology. Okay, I will check again. Okay, so that's the answer.
Okay, thank you very much. So we have new questions coming in. So the next question is, okay, from Abil. How do we utilize MR images for dose calculation on the treatment plan? But I think Kimi already answered it just now, right?
Yeah.
Will you want to top up anything? Either Dr. Kimi or Dr. Kin-Yin?
I think, yeah, for those calculation, it's quite simple, and we just use the bulk electron density override.
Okay, maybe I can say some more words. So in the practice, in the current practice, I think Kimi has answered the question. But for the future, I think the CT, the synthetic CT, okay, generated for the daily MRI may be useful for the future MRI-guided radiotherapy, because we acquire the online MRI, so it can be transferred, converted to the CT immediately for those calculations.
Yes, yes,
so
I do
you mean
agree
from the
with
MRI input?
Yes, use the daily MRI input to generate the online pseudo CT.
Yeah.
Yes,
yeah,
and I think
smart.
also there are research work to do to make sure the like AI algorithm generated synthetic CT. I mean the plan quality and the CT, the accuracy of the synthetic CT number should be accurate enough for those calculations. And I think that maybe there will be another challenge for the online QA to make sure that the synthetic CT is safe for use.
Yeah, okay, great, thank you. Okay, another question. Only online QA is possible if you do online adaptive planning and treatment rather than portal film and point dose. Am I right? Yeah.
That's a very good question. Actually, yeah, currently in our center, we do online QA based on, as I mentioned before, the point dose calculation. Yes, and yes, there's also some trend about the in vivo dose monitoring. So if you use the portal film, it's not like actually it's a portal film in Unity system. Currently, they use the we are able to take the MV portal images, but it's the system said it is not used for clinical. So actually, theoretically, we cannot use the portal images on patients. Yeah. So there's some developed algorithm or the software or in some published papers, they are able to generate they are able to get post-treatment dose verification to make sure the on the day fraction was delivered correctly and accurately on the patient geometry. So that's another topic, I think.
Yeah, agree. Okay, thank you very much. Okay, other questions? Okay, from Ziva, what would be the best possible and practical way to do point dose patient specific QA? It's linked to the question just now. Yeah.
The best possible and the practical way to point those off. The point those do you mean delivery QA? I mean, for the online QA, we use the software to calculate a specific point from the treatment plan. So we actually don't use the do not perform a delivery QA because patient is on couch, right? So we just make sure the point dose calculation by the RedCalc independently agree with the point dose calculated by the Monaco itself within some certainty. So I think if the audience asks how do we perform the point dose patient specific QA in the pre-treatment QA, I mean currently our QA system use the ArcCheck. So for ArcCheck we will have a dedicated QA platform. So we use our platform and then we place the ArcCheck on the platform. So it will have this whole system will be rigidly set up, and then we just insert a pharma chamber in the center of the ArcCheck, and then we deliver the patient specific QA just as the conventional linear. Yeah. So we measure the point dose and dose distribution using the ArcCheck. Yeah.
Thank you. I think we need to have another hands-on workshop, Dr. Kimi, to show examples of those calculations. Right. So there's another question from Tichuan from Taiwan. Recurrent rate, I think it's a MR-guided radiotherapy. Does the recurrent rate lower than other technologies? Dr. Kin-Yin, you are muted. You have to unmute. You're still muted, Dr. Kin-Yin.
Okay.
So yeah, now we can hear.
Okay. So I don't understand this question very well. So what's the recurrence rate meaning here? Okay.
Yeah, maybe I can make some comments on this.
Yes,
currently, there is no trial comparing the result, the outcome of conventional LINAC and MRI-Guided, but there are clinical outcomes coming out, and our center has published several papers. The result of complication and so on is excellent, and we just reported some cases in the journal, cancer journal, and the outcome in terms of complication rate is encouraging. It's too early to say survival, and because it takes a long time to get clinical outcomes of that sort. But initial data on toxicity of rectal complication is excellent with our reported data.
Yeah, I think it is still a very new field. We are waiting for the data, more data from your center. Okay, okay. I think that's all the questions from our participants. Okay, let me go through one more round. Yeah, I think that's all the questions from our participants. Does anyone here have any questions? Can just unmute yourself and speak to our speaker. Okay, if not, we have about 100 participants now. The peak just now we reached more than 150 participants. So it's a very, very good sessions. So we hope to do more similar workshops in the future. So can I go one round with the speakers? Professor KY, do you have any comments or anything, any suggestions that you want to tell our participants?
Yeah, it is a good opportunity to share our experience on the practical aspect and also the background behind having MR-Linac. Just one point I'd like to point out that I debate a MR-Linac, the physics aspect of it, and the quality control of MR-Linac in a previous webinar that was in IOMP school webinar, I think in 2020, a few years ago. For those who are interested into more detail about physics and the quality aspect or quality assurance aspect of MR-Linac, you can view that video still there.
Yeah, that's very nice. Thank you very much for the suggestion. Yes, Dr. Kin-Yin, do you have anything to share with our participants?
Okay, so first of all, I'd like to thank for your invitation. I also like to thank all the participants for their attention and their interest and their participants for this talk. And I also look forward to communicate with all participants more in the future. And maybe we can have some collaborations in either research or the clinical practice. Okay, so let's keep in touch.
That's very nice, very kind of you. Thank you, Dr. Kin-Yin. Dr. Kimmy?
Thank you for the invitation, and thank you, and thank all the audience for joining us in this special day. And we're looking forward to future collaboration and communication. Thank you.
Thank you so much, Dr. Kimmy. I know this is the second time you are sharing about a similar topic. Yeah, thank you so much for that sharing. And for all the participants, the today sessions is already recorded, and we will upload the video, the recording, on the AFOMP website as well as on the social media. So you can go to the YouTube or even Facebook and LinkedIn. So they will share the video there. So please, you can review the sessions today. And if you would like to have any collaboration with the speakers, you are very welcome to contact them. They welcome you here. Right, so thank you so much. And thanks all the speakers. I know Dr. Jin-Yuan, you sacrifice your time for your family and you came to the office. We really appreciate that. And Professor KY as well, and Dr. Kimi as well. And
Thank
to all
you.
the participants.
Yeah.
Thank
It's
you,
our
thank you.
pleasure.
Yeah, so
Goodbye,
before
Rob.
before we end, let me show you the next webinar. This is the next AFOMP school webinars. So Dr. Kimi, again, we will see you again in the next sessions next month.
Yes.
And the speaker will be Professor Shigekaju Fukuda. He is also here today in this session. I'm not sure he is still around now. So we will be listening to Professor Fukuda on the topic on the radiation oncology projects of FNCA. FNCA stands for Forum for Nuclear Cooperation in Asia. So I think the AFOMP committee already sent out the announcement, and you can register for this webinar next month. So for all the certificates, please fill up the feedback form sent by Mary John in the chat, and you will be getting the certificate after this. Yeah, I think Professor Jin offline. Is Mary, are you still here? Mary? Do you want to say something, Mary? Okay, if not, then on behalf of AFOMP, thank you very much. Thank you all the speakers and all the participants for your valuable time. So we'll see you again next month. Thank you. Have a good day.
Thank you.
Goodbye.
Thank you.
Bye-bye.
Bye-bye. Bye.